Welcome, everyone. Thank you again for joining us for this Medical Education Research Methodology Journal Club. So I'm Eric Chappelle, and with Doug Franzen, this is our second annual version of it. Today, we have two great articles, and we are joined by our excellent facilitator, Dr. Dinah Wallen, who is joining us from the West Coast. She's an associate clinical professor of EM and pediatrics at UCSF in San Francisco General Hospital. And Dr. Elle Lett, who is an MD candidate at the Perelman School of Medicine at Penn and a clinical assistant professor in health systems and population health at the University of Washington, and a scholar in residence at the Center for Anti-Racism. And Dr. Tyra Fainstad, who's an associate professor of medicine and internal medicine at the University of Colorado. So for those that haven't joined us before, this journal club is mainly focused, it's not the traditional thing where we do this sort of like soup to nuts discussion of the article. It's really focused on education methodology. So how do we answer the questions that we want to answer? What are the tools that we use? And not in the like high level, I read about it on like a Wikipedia page kind of thing, but like really what do you have to do? Like where do I put my data? How do I get it? How do I think about how I structure like the actual process to get really the nitty-gritty that hopefully will get you to that next level for where you're able to, if not implement this in your next project, maybe a little bit down the line. Doug, I'll hand it to you.
Oh, no, I think that was very well said. And I was just going to say, hopefully you listen in on this, you get some thoughts about methodology that you might use in an upcoming study, or maybe hearing some of these methods gives you some ideas for an upcoming study. And that's really our goal, is just to try and introduce some of these and look at examples of, well done examples of them. So I think that's all I got to say.
Hand it off to you, Dr. Wallen.
All right, thanks so much. And amplifying that, well done. Both of the studies that we're going to talk about today are so cool, amazing findings, and really intriguing methodology. So welcome again to the webinar. As Dr. Chappelle mentioned, I'm Dr. Dinah Wallen, and although I am a career educator and what research I've done has been education-based, I am definitely no expert, and I cannot wait to learn from our discussants. So as we proceed, please put any questions you have in the chat. We're going to have a brief Q&A at the end of the webinar as well. So just toss them in the chat as we go. So our first article is entitled Intersectional Disparities in Emergency Medicine Residents Performance Assessments by Race, Ethnicity, and Sex by Lett et al. And again, we're fortunate to be joined by the first author, Dr. Elle Lett. This paper quantified the effect of intersectionality on disparities in EM resident milestone scores. So just to catch all of us up, intersectionality is defined as the study of overlapping or intersecting social identities and related systems of oppression, domination, or discrimination. In that, aspects of our identities can intersect to amplify the effects of oppression. For example, lived experience of a Black woman is different than that of a white woman or of a Black man, with two minoritized identities, Black and woman, intersecting. So this was a retrospective cohort study of nearly 17,000 milestone assessments for over 2,700 residents. No small task. Unsurprisingly, at least to me, the authors found that URM, or underrepresented in medicine compared to general population, URM female residents were consistently rated lower than white male residents, which suggests that intersectionality is playing a role in the racial and gender disparities that we see in resident evaluations. So let's get into it. Thanks again for joining us, Dr. Lett. We're very happy to have you here. So to kick things off, I am just really curious to hear what prompted your team to even do this study.
So I was working with Dr. Dallin Boatwright, and his sort of entire education research agenda is looking at how to make medicine represent the people we care for, and how to make sure that the process of training is one that's fair to everyone. I mean, I'm applying into emergency medicine, and he's an emergency medicine physician. And it's well documented that, and I wrote one of the papers that shows that underrepresentation in medicine across pretty much all specialties is the same or worse than it was 20 years ago, despite all the efforts. But the question about is why. And so there's so many whys, and one of the whys could be the way we are evaluated, we being everyone, and how that manifests in people's completion of their programs or promotion or retention down the line. And so that's what prompted us to look at this question.
Great. I'm so glad that you did look at this question. And I'm bummed we don't have enough time to really dive deep into the findings, because honestly, that was what was most intriguing to me. I need to learn more about this methodology, though. So with your team, you actually quantified intersectionality, which is something that has effects argued to be multiplicative rather than additive. So really kind of exponentially growing. Can you briefly discuss, A, how you chose this methodology to answer your research question? And then B, the logistics of this methodology, hierarchical mixed effect models. Tongue
Yeah.
twister.
So what I will say is that I don't believe that intersectionality is something that is quantified. I think it just like is. And this is just my 2-second thing just to be on the same page. I view there's a lot of people treat it like it's a buzzword, and there's a lot of tension around methods that are also politicized right now. I think we live in a world where there is power and people have different amounts of it. And we need, as scientists, if we want to study it, we need to have some lens to look at it and to try to translate across it. And that's what intersectionality is to me. It's the closest I can get to take the world that we live in and put it in a statistical regression model or in a study. That's how I use it. And as far as this specific method, intersectionality as a field, there's a lot of hotly debated things, but there's some basic principles you kind of always have to be able to get at. And whatever sort of equity or inequity you're trying to observe, the bare minimum is that it has to be legible across different identities and at their intersections. So you can't just look at a main effect of race or gender. You have to be able to look at Black race and gender cross-strated. That's like the baseline. The reason why a hierarchical model was required was because people are nested. This is a statistical question that's not as much related to intersectionality as it is to getting good estimates, because people are nested in different environments at the state level, at the program level, and in the year that to accurately estimate how they're differing across those assessments, we need to account for that correlation to make sure we're not overestimating or underestimating something. And so just to wrap it up, this method doesn't necessarily measure intersectionality. I assume that there will be intersectionality, good or bad, in anything where we're studying people who have different identities that are patterned along social strata. Instead, I want to make sure that intersectional differences are legible to my methodology. And that's what I did here.
Thank you so much for that. And I think let's take it even a step a little bit more proximally for people who are like me, and again, who have a very rudimentary understanding of methods. We'd love to learn from you how this mixed effects regression is actually different from regular regression. And again, just you started to talk about this, Dr. Lett, and I want to learn more what kinds of questions this methodology really helps us answer.
Yeah, so the mixed effects part is not important for the intersectionality part in this context. There actually are some contexts. Anyway, for this question, we get at the intersectionality part by parameterizing a model such that we use an interaction term, essentially. A little more complicated, but you can think about it like that. So it's an interaction between race and gender, so that essentially it creates a single variable for a URM and a woman, white and a man, and so that you can use that to get the contrast, which means you can just compare. You have a parameter in the regression model that you can literally subtract from another parameter to say what is the difference between these groups and get all those estimates. But the mixed effects part, anytime your data has correlation in it or correlation structure, if I am, this is the most common way to address it. It's also another way, but I'll just for time say that. Dr. Wallen, if you and I are training in the same emergency medicine program, you're a woman, I'm assuming you identify as a woman, I'm a trans woman, and the program, and our scores look different. We adjust for a step 2 score, so assuming that should account for a baseline educational talent. And we want to compare to a group of people who trained at a different year at a different place. You and I are going to have some relationship between our data at baseline just because we're in the same place at the same time. And so the mixed effects, including those effects, including a random effect for place and time, essentially, allows us to account for that correlation and still be able to get good comparisons across those different dimensions.
Got it. That was such a great explanation of such a complicated thing. And now that I'm thinking about all those variables, so we did a binary gender in this, right? And so we've got gender, we have race, we have ethnicity, we have location program, we have year of training. That is wild. That is
Yeah,
wild for
this was
17,000 milestones. Oh my
I
goodness.
trained as a statistician in 2014 and 2016, and quiet is kept. Mixed effects modeling, everyone who does it has to relearn it every time. And when I tell you that I was coding, it wasn't impossible. I knew what I was doing, but it was just like, ooh, gotta dust out some of the old notes for this one.
Yeah. Oh my goodness. I'm so glad you did it though, because I can see where a lot of people would be so overwhelmed by this that they're just not even going to undertake this study. And that question needed to be answered. So thank you. We're going to pivot a little bit from the specific methodology and then into another really important facet of the study, which is we would love to learn from you. How did you get access to all the data that was used in this study? Did this leverage a lot of social capital? How were you able to get this from the ACGME?
So I have been positioned to do a lot of, all right, we're going to be real frank. I don't care that much about representation and equity research as my primary discipline because I think it's every person of color gets pulled into that. I care a lot. I think of it as inward facing. It's super important, but I want to do outward facing work and care about the community. But because I'm Black and trans and a statistician, everyone's we work with me. And so I end up being a lot of these studies. And so people often reach out to me when they have a complicated question and they have access to data that they want to answer it. I can talk about how the people who brought me in got it. And so those are very long-standing relationships. I have worked with 3 different teams who've gotten ACGME data, and they usually bring me in when it's time to do the quant work and write. And I know they'll put me on a data proposal as well, because you have to. And the time between writing that proposal and when it's time when I get the data can be a year, 2 years. And so, in the process of getting the paper published, ACGME has to approve everything you write. So if this paper gets written and then it goes to them, there was like, for instance, they didn't get the exact same numbers as I got because they didn't translate the inclusion criteria the same way that I did for the study. And that halted the paper until we got literally to the last number on the same page. You have to build a lot of trust with these bodies. And I suspect it's because they don't want anything that comes out that makes them look too bad. And so being honest with the data, especially on things that can be this tense, is a challenge. And that's the one thing that I'm pretty staunch about. And so there have been challenging discussions about I can't soften this message anymore and it be accurate. And so either we stop or we move forward and write it as honestly as possible.
Thank you so much for that super candid response. I should have some tea here to be sipping as we're talking because it makes sense, right? The ACGME has their own agenda and their purpose, right? And so I can see where collaboration can get a little bit thorny if things are coming out that maybe the milestone assessments aren't the beautiful, objective, equitable thing that they were.
But to be fair to them, they have been very collaborative. Dr. Darwin Boatwright, who I've done a lot of the papers, who I've done all the EM papers with, has developed really good relationships with people over there, and they always have good intent, and they just, if it's something big or scary, they just want to make sure it's right. And the other stuff that I've worked on with other group teams, same feel. So the ACGME wants to tell the truth. I don't think it's not that. It just also, sometimes it's hard to, when you take a lens and look at yourself and what you see you don't like, sometimes it's hard to acknowledge that.
Yeah, so then thanks so much for sharing that. So it seems to me, if I'm hearing this right and understanding this right, that this is probably not the best data set for a brand new junior researcher that's just trying to get their feet wet to just walk up to the ACGMA and say, give me your data set. It sounds like we really need to have established relationships and trust here.
Some of my earliest papers were actually published based on openly available ANC and ACGME data. You'll be surprised at how much they publish tables, and you can do a lot with just raw tables, but it takes somebody sitting down and typing them into Excel or scraping them off a PDF. Like some of my biggest papers on just like racial demographics of the medical student body or residents over time was from publicly available data and doing analyses from that. But it does take a lot of grit to like hunt for the tables and understand them and go through that. So maybe not the best for, if you're junior and you're really interested in this, I would find somebody who has published with this data before and see if you can jump on to their existing agreement and see if your research styles and agendas are compatible.
Wonderful. Thank you. I think my last question for you regarding this, since you have so much experience using both the publicly available stuff and then the secured things, for this study, really, your team was just utilizing some demographic information. I'm curious, in your prior experience and just conjecture, do you think it would be possible to acquire more detailed information from the ACGME,
Oh
individual scores
yeah.
identified? You can.
Oh, yes and no. Those scores were individual level. Like I got individual level scores. They were de-identified. They were random identifiers. I'm currently working on a study where I have access to people's individual reported experiences of discrimination by gender, and they're for trans folks, which is the first data set of its kind. But they are very serious about privacy. And so if you're talking about small populations, which is inherently the case for this type of work, there will be limitations. For instance, there are so few trans people in the data set that they gave us two data sets. One of them is all the years are collapsed because if they gave us it by year, it would be identifiable. I literally probably know them. And in the other one, they didn't give us the gender identity, but they gave us the year because it wouldn't be identifiable. So those are the tensions. And that's a methodological question. That's a match between what is your question and what are you trying to answer? So what data do you need?
Yeah, thank you so much for that. Okay, now pivoting a little bit again. So you and your team used R for analysis, and I have a question asking for a friend. Can you talk to us about how those of us who are not familiar with R can first kind of access it, dip their toe in statistical software pool without just completely drowning? Oh, I
I
see she's
want to
looking for a
say
book.
this is the best book that I have.
R in action. All right.
Yes. It teaches you how to do it as a process. Like it teaches you some statistics, teaches you some coding at the same time as you go. I think it's almost like a workbook. It's really fun. Tells you how to download some public data sets. I believe in R because I believe that public use, like open access software, is a way to democratize science. If all the institutions use R, the poor institutions that can't afford huge staff and data subscriptions, because it's open access, if something's not good, somebody at Harvard, Penn, or Yale gonna fix it. And then everyone has it right. And there are some things you have to get hacky. SAS is better at big data. Stata, all the economists use them, and you gotta work with economists sometimes, unfortunately. But just kidding. They're great. But I think that is really important. And I think that having some literacy around open access software is really important for people if they want to get hands on. That being said, I don't think everyone should be doing their own analyses. Even simple analysis can be complicated, deceptively complicated. So I think I don't mind a clinician who has played around in their data a little bit, but I do not think that most analyses should be done by people who don't have quantitative training.
Woo!
And
I feel so seen. Thank you so much for saying that. Agreed. Thank you. We'll give you a brief moment off of the hot seat, and I want to turn over actually to Dr. Chappell wearing the editor hat. So Dr. Chappell, again, is a decision editor at AEM Education and Training. And I'm curious to learn from you as an editor, what are you really looking for when you review a paper using this type of methodology, especially something that's so complicated? I know as a reviewer, I would have a hard time reviewing this paper because I just don't have a deep enough stats understanding.
Yeah, I think this really dovetails really well with what Dr. Lett was just saying, which is like these days it's so easy to download whether R or Stata if you have a subscription or whatever. And if you have a data set, you can turn it into numbers and you can put those numbers in a paper and you can talk about them, but it might be completely wrong. Like with the nesting. So like when I think about mixed effect, anytime you have a cluster, if you're like, okay, I have all these points on my plot, but like this hospital is different than this hospital is different than this hospital, that's when I'm using mixed effects. And if those hospitals are nested within states, then it's really important to get that relationship right. And if you just put them in the opposite order in your statistical software, like you're going to get totally, all of a sudden states are nested in hospitals, and that doesn't make any sense. Your numbers are going to be totally different. And so the ease with you can totally screw up your analysis if you don't know what you're doing is magnificent. But the output still looks, the numbers might not make sense, but it'll still give you a beautiful graph, or it'll give you the numbers, it'll give you confidence intervals, and you can write about them. And so what I'm looking for when I review something with mixed effects is like, are there all the breadcrumbs that make it look like this person knows what they're doing? Because you aren't going to know. I don't know in what order you put your nesting. But reading this paper, I'm pretty sure you got it right because all the stuff is there that makes it look like this person is discussing this methodology in a way that it seems that they know what they're doing. And like, sure, you could ask, okay, give me your syntax for like, how did you write that or whatever. But like in rare, I've never done that before, and I don't know if I ever will, unless I was really suspicious about results. But all the things like the attention to detail in how and why certain things are like either controlled for. So are things included as a control? Are the groupings associated the way that you would think? And are the relationships as described in the methods part put in a way that seems to make sense? This paper is great because it very specifically says what the layers of nesting are. It says what the fixed effects are. It says what the random effects are. And it goes so far when you're organizing by either program or hospital or whatever it is, whatever your clusters are, you can also say that, okay, each cluster has their own intercept, meaning it can start from different points on the graph, or it can have a different slope, which is even more complicated. And so do they mention what they did for sort of fixed and random effects? Did they allow different slopes? Did they allow different intercepts? Intercepts is usually level 1, slopes is the level above that usually. And so is all of that described the way that you would expect? And do they have the attention to detail that makes it look like, again, this process makes sense? And so in this one, the thing like including academic year, because if program leadership turns over and all of a sudden you went from a Dove rater to a Hawk rater or vice versa, if you change the PD, you might totally change the way milestones are done, and you wouldn't see that, or that wouldn't be accounted for if you didn't have the control by academic year. And so reading through something like this, it's like easy to see that the people knew what they were doing, that Dr. Lett knew what she was doing. But sometimes that's not the case when it's just like, I did a regression, and it's more common in regular regression than in mixed effects. Most people that dare write down mixed effects in their manuscript usually know what they're doing, but maybe not. So for regular regressions, I feel like it's more common. It's just like, I have this data and I did a regression, but if all the sort of trappings aren't there as well, then I start to become a little more questioning of the methods.
And just in like most statistics, I'm also an editor at Health Equity. Most statistical methods, there are things that are accepted as best practices, and there are some gray areas that we don't know. It's still unknown if you have a random effect that's not statistically significant, whether or not you should include it or not. And these are the kind of things that when I'm evaluating, I want to know that they at least wrestled with this so they knew to consider it.
Thank you so much. And I think kind of closing out this discussion and trying to then open up this complicated methodology to broader groups of people and author groups, I think this is a question for both of you. For people like me who are intrigued but a little overwhelmed and want to just start to learn more before I even approach a statistician to ask for support or collaboration, where can we learn more about the mixed effects methodology? Any recommended resources on that, besides getting a PhD as you did, Dr. Lett?
I think Ana Diaz-Ruiz, epidemiologist, wrote some of the classic and accessible, just saying like, why we do this kind of papers, and I can look for them and send it. I think that's it. That's really good. I will say to demystify some of these hierarchical models, mixed effects models are the same things. GEE is not the same thing. It's a honestly hackier approach to doing it, getting at it, but it still works, but only if you have one level. And I think statisticians own this being more complicated than it needs to be by having so much different language for the same thing.
Isn't that right? Yeah, that's the theme of medicine too. Like this, how we keep everybody out is by making up more words for things we all know. Thank you so much for that. I think that's going to wrap up our discussion of this first article. Dr. Lett, thanks so much for doing this research. Thank you so much for being that stats brain to support these other teams that have great ideas, but maybe not the skills yet to make it happen. And thanks for putting this out here. This is amazing research, and we just really value your time and your wisdom and expertise. So thanks to you. Thanks to Dr. Chappell for sharing your thought processes as well. Listeners, please remember, if you've got questions or comments, please go ahead and put them in the chat for this article and then the one we're about to discuss. So we'll try to answer questions in the chat as they come up if possible. And then if not, we will have a Q&A section right at the end. So our second article is entitled Online Wellbeing Group Coaching Program for Women Physician Trainees, a Randomized Clinical Trial by Mann et al. And we're incredibly fortunate to be joined today by Dr. Tyra Fainstad, the senior author. Welcome, Dr. Fainstad. So this study was a randomized clinical trial. We don't see a lot of those in education research, involving women identifying trainees from 26 institutions located in 19 states, including over 1,000 subjects. Trainees were randomized to an intervention or a control as per usual. And the intervention in this case was enrollment in the Better Together Physician Coaching Program, which is a 4-month online group coaching program developed by the first and last authors of the current study, and then was delivered by physician certified life coaches. The primary outcome was a change in burnout measured by the Maslach Burnout Inventory, or MBI, subscores in emotional exhaustion, depersonalization, and personal achievement. And then secondary outcomes included changes in imposter syndrome, moral injuries, self-compassion, and flourishing. And the authors found that for women identifying trainees, participating in the coaching program was associated with decreased emotional exhaustion, depersonalization, imposter syndrome, and moral injury, and increased self-compassion and flourishing. No big deal. So Dr. Fainstad, congrats on completing such a massive study with impactful results. And just to start things off, we would love to learn what prompted you and your team to do this study.
Oh, thank you so much. I don't think I've ever sat and had somebody summarize my own work in front of me, and it's just a little cathartic, actually. I'm so happy to be going second after such a beautiful setup by Dr. Lett to frame me as a clinician who really, before I started down this track, I didn't even consider myself a research person. And so I've had to really learn the ropes kind of by doing it. It's really been flying the plane while I'm building it. But what prompted this ultimately was just a deep passion and mission towards improving the well-being of residents and fellows to start with. We now offer this program to students and attendings and research faculty also. But we started in residence because it felt like a really vulnerable and powerful time where you're sort of forming your professional identity. I know, at least personally, it was a time where I developed some really bad habits of self-sabotage, praise addiction, and a very loud inner critic. And the idea that I had to beat myself up constantly in order to do well. These, I found, are not just limited to me. And I was fortunate to stumble sort of accidentally onto coaching, which was a complete game changer for me. Also, at the time, I rolled my way into it because even just 5 to 10 years ago, coaching was like not really legitimized in our field. And I remember thinking it was maybe somewhat adjacent to a life cheerleader or something, but it certainly wasn't evidence-based or a real tool that was talked about in academia. So once I got some and realized how incredibly powerful it was, I knew that in order to amplify it or spread the word, I wanted to academicize it. And I knew that the best way to do that, like our love language, is RCTs. And so that is what we set out to do. We initially started with a pilot RCT the year before here at the University of Colorado. Dr. Adrienne Mann and I co-created and co-direct this coaching program. And then once we got some traction there, we wanted to do this big national RCT sort of to be powered to find the real difference that was there and to make sure that it was generalizable.
Thank you so much for that. And I love that you started with residents, and I agree they're our most vulnerable and mistreated and saddest group.
They are. Yeah.
Sorry, Dr. Lett, not to missell what it's going to
Yeah.
be soon for you, but residency is very hard. So thank you for centering people that are often not centered with that. We now shifting into our methodology discussion, we got such a wonderful description of the mixed effect logistic regression in our previous studies. So we're not going to focus on that as much. Way to save you on that one.
Truly. Thank you, Dr. Lett.
Yeah. So what I'd love to hear from you, the methodology was an RCT with this intention to treat pre and post analysis. And you did use the mixed effects logistic regression. So we won't talk about that part, but what are the logistics of this methodology, the pre-post? We'd love to hear a little bit about that.
Sure. Essentially, we created this program and then enrolled whoever wanted to volunteer in it and identified as a woman. We started with women because those outcomes that you mentioned that we studied are so much worse across the board in women compared to men. So we went to where the need is greatest. And we offered this coaching program to them. Then we got our arms around, we basically just asked leadership or program directors, chairs, deans even to email out to their listserv, our recruitment emails. And then whoever wanted to could volunteer in. At that time, they were randomized to either a control group or an intervention group. The control group, importantly, was a waitlist control. And so we were going to offer everyone this resource. We don't ever want to withhold coaching from anyone, but they were going to get the coaching after the study was over. And so that's what happened. Or they were randomized to an intervention group. In this case, the intervention group got the intervention from September through December of 2022. And then the control group got the coaching from February through May of 2023. And everyone received the same pre and post test, which has demographics and those validated scales that you mentioned before. And we importantly analyzed with an intention to treat a lot, because actually we on purpose didn't measure engagement. Everyone was auto enrolled, but during our pilot, something that we found as feedback was that residents felt really overwhelmed, even knowing that we don't grade, this isn't a course for them, but even knowing that someone was watching if they checked on the website or showed up to the calls was very stressful and had sort of a counterproductive result. And so we wanted to make sure that residents really felt like we use this how it works for you. The coaching program itself is multimodal. It has live group coaching calls, which are recorded for later listening if you miss one. It has an online curriculum of sort of 16 weeks of worksheets and webinars where we talk about things like imposter syndrome and creating confidence. And then it has written coaching, unlimited 24/7. You can write in a coaching request and we write back. So people can interact with it as they choose, however much they choose, whenever they choose. And we didn't want them to feel watched since we knew that was really stressful. We measured everybody's scores, whether or not they got a ton of coaching or never touched the program. What we know anecdotally afterwards is that people who did very little, passively engaged, maybe came to a coaching call but never got coached, or maybe they didn't even come and just got our weekly emails, their scores also improved. But again, we didn't do direct raw individual engagement level measuring. So everybody got the same pre and post test, and then we compared our control group to our intervention group to see what the difference was.
I love that. That's such a subject-centered, nuanced approach to doing this. And it's true that sometimes just knowing you have the resource, even if you never touch the resource or open the resource, knowing that there's something there for you when you need it actually can be really helpful. So I love how you thought about that and approached it and incorporated your pilot data into how you actually implemented this. Now thinking about, goodness gracious, the sheer size. So both of these studies, Article 1 and this, these are massive studies. So again, it was an RCT, 26 sites, over 1,000 participants. Can you talk with us a little bit about how this group of programs even came together, and then the challenges for lessons learned, because I'm sure there were some, for managing such a large study of people in real time?
Yeah, I think what I want to do first and foremost is just normalize again the fact that I don't have research training. And the step number one for me was really, honestly, I had to coach myself a ton into a new identity, because for the prior 10 years of my life, I had fully labeled myself as not a researcher. No way can I do that. I had a handful of failed attempts. And so to even dip my toe into an RCT, I had to have a really good why, which I did. But then I also had to build the confidence that how I identified in my work was going to be able to pull this off. So I decided that I was just going to try it. I remember thinking, I'm just going to keep throwing spaghetti at the wall. And if it fails, it's okay. Nothing huge is at stake. This isn't a large grant funded study. In fact, I had a teeny tiny internal grant, and otherwise everyone just volunteered their time. So I felt truly like this was just an okay place to make a mistake. And I did make a lot of them. I was very fortunate to learn early on that I needed a PhD level biostatistician by my side. And so the methodology part was, that person was with me in the planning stages all the way through the documentation stages. And I don't think it just isn't possible to jump in. I could buy this book about R in action, but as Dr. Chappelle mentioned, I'd make 100,000 mistakes, and I was so lucky to have one of those people on my team. So that was really important. And then it was just, I watched hours and hours of modules in REDCap, which is our survey database, and figured out how I wanted to make my surveys. And we tested them, a whole bunch of test groups at first. And it was like, oh my gosh, this is way too long. What can you take out? And then we retested them. And oh my gosh, this branching logic didn't work. And then we retested them. And it was so many mistakes. And I think a prior version of myself would have stopped at mistake number 3. And I just kept going with my I'm just throwing spaghetti at the wall. thought in my head. Now, how do we get 26 sites? Oh my gosh, I have no idea. I think we were brave because our intervention was so incredibly scalable. We did the pilot here at the University of Colorado, and we had 100 participants. We cut ourselves off at 100 because we just didn't know how many we could coach at the time. The model of this program is group coaching. So it's like this: we're on a Zoom webinar call, and I could have 30 people in the audience, and I might coach 3 of them live in front of each other. Or I could have 3,000 people in the audience, and I still coach the same 3 people live, only now in front of 3,000. And what we knew from our pilot and a qualitative study that we did was actually the biggest impact of the program didn't come from people who got directly coached. They got an impact, and that's been well documented too. But the power of the group coaching was hearing your peers' challenges be normalized was so incredibly impactful. We've really felt that's what elevated this program. So then it was like, gosh, why don't we enroll 10,000 people? Let's go. I remember the day Adrienne looked at me and said, why don't we do another site? And then it was like, we could get a third site too. I'm from Seattle. Let's get UW. And she had some connections at Emory, and all of a sudden connections led to connections, and we had 26 sites. We wanted a good representation of small community programs and larger academic programs, and then a geographic distribution. And we aimed to sort of match the ACGME demographic participant data, which fortunately we did. But other than that, it was just pure grassroots networking.
My goodness. Thank you for sharing that. And I think so I'm hearing some common themes as we've been talking with both of our authors, thinking about, number one, personal connections are important, right? Like just straight up, like when we meet people, and that's really hard for me as an introvert. Like I hate walking up to people and introducing myself at conferences, but it's important, right? And taking advantage of those opportunities to really get to know people. Secondly, how important it is for a trained expert biostatistician to be involved from basically the inception of the project to really understand, until someone understands really what they're doing. And just really being flexible, being humble, knowing that there's mistakes that are going to happen. And if the work is really important, really persevering through anyway. One final question about the scale. It did seem a little bit challenging to get follow-up data from participants. And again, as an educator, I know how hard it is to get residents to fill out stuff and to find them. How did you attempt to reach as many people as possible?
Oh my gosh, we struggled. So what we found out from our pilot was that monetary incentives really work for getting those follow-up responses. And we weren't funded to be able to offer that in this study. Unfortunately, like I said, I'm not a researcher. I didn't have a big grant. Gosh, did we try? We sent out what I thought were beautiful, elegantly worded plea emails that the IRB approved for us to ask residents to fill out our post survey. And then we were able to get approved. I just entered them into a lottery I think this is probably one tip. I hope it's okay to share, but I put like $100 Amazon gift card and said, you'll be entered into a lottery if you fill out this post survey. And so that was one way to get around that actually managed to get us. I think we ended up getting 40%, but there was a time when we were at like 18% and thinking, oh gosh, we're not gonna be able to show anything. So I really do, at the end of the day, incentives are so powerful. And we learned in this study that I'm sure Dr. Lett could talk about this much more elegantly than I can, but there are ways to get around missing data. And that sensitivity analysis that we ended up doing at the end was really a way to make sure we could. I remember my statistician told me it was a stress test for your missing data. In theory, it's let's see what happens if we pretend that all of them had terrible scores, or that all of them had great scores, or that there's any number of ways that they responded, and just see if our outcomes hold up. And if they do, then you can feel pretty reassured that your outcomes held up among your data set.
Thank you so much for sharing that part, because that was actually a question I had, was a little bit more about the sensitivity analyses and then how you treated the missing values. So I think this is an important point for our listeners to understand a little bit. You and your team used imputation for missing values. And so we would love to learn a little bit about, number one, what imputation is, but secondly, why you chose to use this rather than just dropping observations that had missed values.
You mean why do it at all?
Yeah. Rather than just tossing them out, saying, never mind, they didn't do it, they're not part of it.
Oh, sure. I think we wanted to keep our power was the main reason to really do this. And it is a huge limitation. And we write about our missing data in the limitation section. It's probably our number one limitation. And so this was kind of like the best way that we could think of to ensure that wasn't necessarily that our program did still work even with all of this missing data. And then in terms of like the specific, I'll tell you the limits of my knowledge are that there are like half a dozen different ways you can actually do a sensitivity analysis. And the method of using imputation felt like the best one for our study within the realm of what my statistician could do. I'm curious to hear what Dr. Lett would have to say about that. But I think it was kind of like, this is the best we can do with what we have.
Yes. I would love, Dr. Lett, if it's not to put you on the spot, but if you do have thoughts on that.
I
would
love
to
talking
learn
about
from you.
missing data and imputation. Just to be clear, I am a master's statistician trained and PhD epidemiologist, but very comfortable with the quant stuff. Imputation is basically a best guess of what the data would have been based on the data you have. And it has a series of assumptions that you have to be able to make a case for them being valid. Just to be quickly, it depends on, based on conditional on what you have, can you say that that missing miss is basically random? And then you can make a good imputation model. The answer is actually always no, but how no is it is really what the question is. And how good do you have? So I think of imputing sensitive things like race and gender, I think should never be done, because there's so much that those things end up being proxying for that it creates this no matter what, you end up incorporating bias. That's my personal opinion, others will differ. But if you can say that the people you're imputing kind of look like the people you don't have the data for, and you want to preserve power, then sure. I think that what you all did by doing that sensitivity analysis, by saying we imputed it, which gives us our best guess, but now let's say what is the worst that could happen versus the best that can happen, is consistent with the best practicing for it. But in general, I would consider it a major limitation.
Thank you so much. That's so helpful. Yes. Thank you. I think before we transition quickly over to Dr. Franzen for the editor perspective, the last question that I've got for you about the methodology, Dr. Fainstad, is regarding the instruments. So you use so many instruments in the study, the MBI, the Young Imposter Scale, moral, so many. And so curious just sort of how that happened, how you found the instruments. Are these pretty much the only game in town and that's what you had to use? How did you pick and choose, and how hard was it to acquire licenses and permission, especially without money?
Yeah, that's a great question. The only one that we spent money on was the MBI, and that has to be licensed through mindgarden.com. And we had written that into our original pilot grant, and it covered us, fortunately, for a number of years. That one's kind of it's our primary outcome. And so we really wanted a gold standard, and we were willing to sacrifice both cost and survey question length for that one, because that's also a lengthier one. But it is generally considered a gold standard. It's been validated in healthcare professionals, of course, and in residents specifically. It wasn't built to be a binary score, but it has been used in a binary way for a long time. Lots of medical education researchers have used cutoffs for emotional exhaustion and depersonalization. Again, I don't think that was how it was built. In fact, I know that it wasn't, but that's sort of out there. And so it allows us to do fancy things like say, hey, look, this is on average how burnt out people are across a population. So that's why we chose that one. The others were a mix of what is free and available and has been validated in our group. And no, they are not the only game in town. There are many ways to measure well-being. We felt strongly about imposter phenomenon and moral injury as just in an informal needs assessment, and honestly our own personal experience of residency has those topics coming up so frequently. And the Young Imposter Syndrome scale is probably the most controversial one that we used, because there is one that's better validated. It's the Clancy imposter phenomenon scale. It was much lengthier and expensive, and this one was free and short and had been validated in residents. And so that's the quick and dirty answer of how we ended up with that one, and it's sort of how we ended up with a lot of them.
Thank you so much. And Dr. Lett, yes, please.
Just a 2-second note on validation. Validation is time, context, and group specific. And this is something I feel like everyone should know, is that you're always allowed to be critical about what's labeled validated, because in truth, as soon as it's validated, it's no longer valid, to be honest. It's obsolete. And so think critically about why you're using it and when you're using it, because I think I've seen a lot of times someone says, oh, this is validated in doctors, but it was validated in 1970 when the demographic of the doctor population was friends and the mayor and nobody else in this room.
Yeah.
So,
Oh my gosh, I love that. Once it's validated, it's obsolete. So good.
I was just going to ask my final question about this paper is actually for Dr. Franzen. Again, just going for the editor perspective, because I know that as an educator researcher, pre-post sometimes is poo-pooed because of course there's going to be a change if you got something, right? If you learned something or got a lecture, you're probably going to have, there's going to be a change. And so what made this study stand out? And then also just thinking with pre-post methodology as an editor, like what do you really want to see to be able to put it out there?
Yeah, wow, that's a big question. I think I want to actually start with what you guys just ended with just using these validated, I'll use that loaded word, indexes like the Maslow burnout scale, right? Because you get a lot of studies that are pre-post and they'll use sort of like a homegrown tool. I wrote this 20 question multiple choice thing and people did better after we did our educational intervention. And it just makes it really hard to sort of put your intervention into context, right? So when I have this tool that's been out there, it's been used, it's been studied, it's shown up in other studies, it makes it so much easier to say, okay, this intervention compared to other interventions, and Dr. Fainstad's group did that, right? They said, our interventions seem to show better results, better improvement in this scale than here's 14 other studies that they cited. And that's fantastic. And then another piece of that is the MBI has also been shown to correlate with some other things, right? So there's an association with lowered suicidality with scores in the emotional scale and things like that, right? So now as an educator, I can take this thing and say, okay, not only did students get some different number on a score sheet, that number actually means that they're less likely to harm themselves. They're less likely to have medical errors. And that like a huge thing, right? That's what we as educators really want to do. I don't want to teach to the test, right? I want to make better doctors. I want to make people who are happier doing what they do. And I think that's really the power of using something like this, right? Is those things get put into context. And you could use that anywhere, right? Imagine, again, my 20 question multiple choice test versus like the cardiology section of the emergency medicine ITE, right? If I can show improvement in that, every program director in the country is going to be interested in whatever that educational intervention happened to be. And it's really just humongous. And that if you walk away from this session with any one piece of thing, I would say, if you're going to do a pre-post study, for the love of God, use something that's already been published, already been studied, already out there in the literature so that everybody else can use it and compare their thing to your thing so that we can all figure out what's doing better. So that's my biggest one. The other cool thing about this study that really kind of caught my eye when I was reading it was it's a scale up. Right. So you had done this pilot survey. You did it. I think it was the single site at Colorado. And now you're doing it at 26 sites in 19 states with 1,000 different people, trainees at all levels, VA sites, community sites, academic sites, you name it. And you already touched on that, right? That generalizability was a big question that you were trying to answer. But think about how much stuff we do in education where you sort of start off with this small thing, right? And then your dean comes to you and they're like, hey, students love this. Will you do this for all 250 of our students? And you're like, sure. Right. I mean, because education it's small when it's one-to-one, or it's easy when it's one-to-one, or it's a small group, right? And I think sometimes the power of what works well is because of the person in charge of that group, right? You have this fantastic educator or this really interested person or this wonderful expert. And when you start trying to scale that, like it doesn't necessarily always work out that way. And so that was a really another neat thing about this was that you showed like, no, we could do this with 3,000 people and it still works. And so now, right, as like a dean or an administrator or somebody who's looking into bringing different programs in or adding stuff to our overall curriculum, like that's really appealing. So I think I got a million other talking points I can have here, but I know we're almost out of time. I want to have there's questions going on in the chat that I thought we should get to. So.
Thank you, though. Like I get what I'm taking from this is it meaning. It has to have meaning and not just numbers. You know what I mean? That there really needs to be something behind it. So thank you so much. That was helpful. I am going to just quickly transition to Dr. Chappelle for 1 to 2-ish questions from the chat to highlight if we can before we close.
And I tried to answer some as we went along, but there are some comments about sort of the differences from the first test, from the first study, as well as a comment about RCTs. But any additional questions from others in the audience?
Okay, then
Think
I
you
would
got 'em.
love to give each of our discussants like 15 to 30-second final closing. You get your final words. So we'll start with Dr. Lett and then to Dr. Fainstad, whether that's advice, whether that's just rumination on your data. We just are your final closing words.
I'll be quick and say that I really appreciate what Dr. Fain said about redefining herself. And I think one of my most important mentors is the reason why I'm a scientist. And she said the difference between people who can write a paper or they've written a paper. And so I think as long as you temper it with humility, be curious, ask the questions. And one thing that I've learned over my time, I've been doing science for over a decade, despite being pretty junior, and that even those things, when the confusion that I had before I knew a lot was actually pointing to really good questions and really good things that didn't make sense in the field, like why do we do this model? If no one can answer your question, that means that the answer might not be out there, and there's a reason why you're confused. So you can trust your gut as long as you temper that with humility and asking experts for help.
Thank you. Oh, it's so inspirational. Thank you. Dr. Fainstad.
That was so inspirational. I just want to end on that. And I do think I can touch on one of these questions in here and kind of give some parting words. Michael Sobin was asking about how to, usually an RCT like this is off limits in medical education. And gosh, the IRB, what a nightmare alone. And how would you possibly go about convincing stakeholders? And those things were massive, scary barriers to me in the beginning also. In fact, I will tell you, so I had one internal small grant that supported the analysis of this study. And the first time I applied for it, I was rejected because they said those things. There is, step back. You can't scale this up by 10 times. Like it was, okay, honey, you can't do this. People don't do this. Maybe try a 2x or a 3x scale first. You'll never be able to get the IRB approved. You'll never be able to generate the sites. And at that point, I actually had already gotten the IRB approved and I already had networked my way into those 26 sites, which the reviewer clearly hadn't read that in my application. So I had to write this huge appeal that was like, oh no, I already did those things that you said I couldn't do. The point is, I think there's a lot of things that our culture says just can't be done. And like, oh, well, you can't do an RCT because of this. And I think my naivete and my junior status in the research world was exactly what allowed me to go for it. Just like Dr. Lett was saying, I didn't know that I couldn't. And so I just did it. And I cold emailed DIOs across the country and asked to come present at a GMEC meeting of just big institutions. And I didn't know that people didn't do that. And so I just did it. And that's how I got the sites. And this one led to this one. And I talked to this one about our favorite type of latte and this one about how rainy it was. And all of a sudden I had 26 sites by accident, it felt like. And I had all my data here at CU. So actually only needed one giant IRB with a few exceptions of sites that had their own structures that needed to be worked through, but it just wasn't the beast that I thought it was going to be. So I want to amplify what Dr. Lett said and do not let your junior status get in your way. In fact, it's probably a blessing.
I love that. I love that. Yes. So thanks so much to all of our discussants. I know I learned a lot and I'm so glad to be closing on this note that it's not just that I need to just go stop. There's still potential left for me. So thanks again to everybody. Thanks to the SAEM Education Committee for organizing the webinar. Thank you to Dawood for being our admin person. Please do stay tuned for future sessions to help all of us really stretch ourselves as clinician educator researchers, and come join us on the education committee to nerd out over education even more. We love it. So I hope everybody has a wonderful rest of their day. Please stay warm. It's very wet here in San Francisco. So thank you, everybody. It was lovely to gather with you. Thank you so much.
If I could just do a quick push for the Education Research Committee of SAEM, also for those of us or you that are doing research, as a great place to network.
Thank you so much, Dr. Mayer. Bye, everybody. Thank you.